Hello, good evening. My name's Euan Lawson. I'm the editor of the BJGP, and welcome to our very first BJGP webinar. So the theme today is health inequalities, and I'm delighted that we've got three primary care GP researchers who can enlighten us and inform us around some of the research and analysis we've recently published in the BJGP. But first of all, I need to introduce you to our chair for the evening. It's the wonderful Dr. Carey Lunan, another GP, recently been awarded MBE for her services to medicine, and particularly her presence during the COVID pandemic in the last year as chair of RCGP Scotland. She's moved on from that and is also now chair of the Deep End Group, as well as continuing her work in a Deep End practice in Edinburgh. Thank you very much, Carey, for sharing. You're an ideal person for this evening. I'm very grateful you could join us. And I'm thrilled that everyone else is here as well. Thank you. So I'll move on now and I'll hand over to you, Carey, for the rest of the evening.
Thank you very much, Euan, and it's a great pleasure to be here chairing this BJGP webinar on health inequalities, and thank you for that lovely introduction. It's a pleasure to be introducing our speakers for tonight and also chairing a panel discussion at the end. We've got three great papers to hear about and discuss this evening, all linked by the overarching topic of health inequality, but covering a diverse range of topics from excess mortality in the COVID first wave to the disproportionate impact on BME communities during COVID, to HRT prescribing and socioeconomic status. And of course, 2021 is the 50th anniversary of the inverse care law, first described by Dr. Julian Tudor Hart in 1971, someone who needs no introduction. And the inverse care law, of course, as we'll all be familiar with, describes a situation where those most in need of healthcare are often least likely to be able to access it, a situation that is worsened when healthcare is exposed to market forces. And it could be argued that never before has this been as pertinent as it is now, and all three papers do touch on this principle. In the context of COVID-19, the pandemic has shone a spotlight on pre-existing significant health and social inequality with disproportionate impacts in terms of disease severity and death rates for those groups that are already marginalised. So before we hear from our first live speaker from this evening, it gives me great pleasure to share an introduction from Professor Sir Michael Marmot. And for many of us listening again, Michael needs no introduction. He is the Professor of Epidemiology and Public Health at University College London and currently the Director of UCL Institute of Health Equity. And in 2010, he published the Marmot Review, Fair Society, Healthy Lives, which was a landmark study of health inequalities in England. 10 years later, in 2020, he published the follow-up report on health equity in England. And the results, the findings were pretty damning. This was before, of course, the global epidemic had taken hold, wreaking havoc across some of our most vulnerable communities. And he's a personal hero, I think, to many of us, I'm sure, on this call tonight, particularly working in the areas of health inequality. I first met him a couple of years ago when he gave the keynote address at the RCGP annual conference, and his insights and his words and his challenges and his call to arms resulted in the longest and the most emotional standing ovation that I have ever seen. Sir Michael is not able to join us in person tonight, but he has recorded some opening words for this webinar, which I'm now delighted to share with you. Thank you.
I probably first met him in the 1980s, speaking at a meeting that he was speaking at, so I can't claim to have met him. And what impressed me all the way back then was how dedicated he was, how serious he was. I mean, just how passionate he was. And I thought, this is remarkable. Somebody who's passionate, enthusiastic about what he's doing to improve the health of people at the coalface, literally, the miners and their families in South Wales in the valleys. So, and then my contact with him over the years was desultory. I didn't meet him often, but it was somebody I kind of knew. And then I reviewed his book for The Lancet. And that was an experience. It felt like I'd been in his living room, talking to him, reading his book, and reviewing it for The Lancet. And I said in my review, I've got a confession to make. I'm a Tudor Hart fan. So I thought I should confess to my bias, so anybody reading my review would know I'm a fan of Tudor Hart. And then I gave it a glowing review. And I think Graham Watt got in touch with me afterwards and said, Tudor Hart was so pleased with your review of his book. But I didn't do it to please him. I did it because I'm just so impressed by this passionate man who's absolutely committed to the NHS and what it stood for, and for doing the best by his patients. I wrote a piece for the BMJ on the 70th anniversary of the NHS about the inverse care law. And I had given the Tudor Hart lecture in Cardiff in, I think, November 2017. And Julian was ill, but he sat in the front row taking notes. And then he wrote to me afterwards, engaged with it. And when I first heard about the inverse care law, I thought, given what I do, which is focus on the social determinants of health and inequalities in health, and given that we've got a National Health Service, that's not the main issue in Britain, that lack of health care being the issue for health inequalities. And then having known about the inverse care law my whole adult life virtually, when I decided, I was invited by the BMJ to write about Tudor Hart, I thought I'd better read the paper. That was an insight. So the paper is very clear. Message number one, the key determinants of health are the conditions in which people live, and that the health of the people in South Wales are related to housing and nutrition and relative poverty and working conditions and or unemployment. So he's crystal clear about that. Second, he says, in a way, the paper is an argument. The NHS solved much of the problems of inverse care. Those problems of the inverse care law, less care for those who need it, is what comes from a market-based system. And he wrote in 1971, there are calls to return to a market-based system. Don't, because of the inverse care law, because the NHS solved the inverse care law, and that's not what we want to return to. And I should have read the paper when it came out instead of thinking I knew what it was about and it was irrelevant, because when I read it, I thought, yeah, he's not saying that despite the NHS, we still don't have adequate care for those who need it. He's saying the NHS solved this major problem, and don't go back to a market-based system. It's a pity that successive health secretaries, they're really healthcare secretaries, didn't listen to him. You know, the Lansley reform said we want half of care to be in the market, to be delivered by private. I mean, this is ideology. Now, you might say Tudor Hart was ideological. Well, he was, but he was appealing to evidence that market-based systems lead to suboptimal distributions. And the third point in his paper, so the first is very important because that's germane to what I do. It's the inequality in conditions in which people are born, grow, live, work, and age that lead to inequalities in health. The second point is the NHS has been brilliant in making sure that maldistribution of health care doesn't increase those unfair inequalities in health, what I call inequities. The third is there are still inequities in care, particularly in relation to mental health. And he wrote to me after my Tudor Hart lecture in 2017, a long handwritten letter. I think he had trouble with his computer, a long handwritten letter. And he died not so long afterwards, but he said there's some call to reduce the number of GPs. And you could do that if you lived in Beaconsfield rather than Glencorrie. If you lived in an affluent area. You could do that if you didn't want GPs to get involved in public health. And you could do that if you assumed that the brain was not part of the anatomy of patients. So in other words, don't do it because more deprived areas need GPs, because GPs should be getting involved in public health. And that's part of an argument I've been having more recently. How can we get the health care system to address social determinants of health? And the third is consider the mental health of patients. And GPs need to do that. And then when you consider the mental health of patients, when you look at the social gradient, the lower down you are, the more deprived the area in which you live, the greater the mental health problems as well as physical health. And Tudor Hart rightly saw primary care practitioners, GPs, as being central in managing the mental health problems of patients. I had a very interesting experience in New Zealand, and it would not be terribly different in this country. I was invited by the New Zealand Medical Association a few years ago, and they were terrific. Not just that they were graceful and gracious hosts, and they were, but they were actively engaged in what I was talking about. Actively engaged. How can we work with the conditions in which our patients live and improve the conditions? So it was brilliant. And then at one point, one of them made some off-the-cuff disparaging remark about public health. And I thought it was really interesting. They didn't see me. I'm a professor of epidemiology and public health. They didn't see me as public health. They didn't see what we were talking about together. We'd spent 3 days together. I was in meetings with them morning, noon, and evening. And they didn't see it as public health. They saw public health as these boring guys who do something about something or other, but it's not what we're talking about. And I've had similar reactions from GPs. Yeah, we're very concerned with the conditions in which our patients live. Just don't confuse us with public health. Well, Julian had no problem with that. He wasn't going to get involved in those disputes. He knew GPs, qua GPs, had to be involved in the health of the populations that they serve. And that's his language, that they work together with the communities that they serve. And that's part of public health. So, yeah, I understand. But, I gave a lecture to the Royal College of GPs, one of the named lectures. I have to add a year to everything because of lockdown, so I can't quite remember if it wasn't last year, whether it was the year before or the year before that. And it was very clear. The attendees at that conference, all GPs, and the leadership of the college, all GPs, were a natural audience for my message and natural allies for what I'm trying to achieve. So precisely because GPs understand. I mean, if they have all their considerable capacities working, they understand very well how the conditions of their patients' lives impact on their health. And perhaps at some points, they might have said, well, that's not my job. My job is to treat their diabetes or hypertension or whatever it is. Perhaps some GPs are saying, no, my job is to look at the conditions that give rise to the hypertension or the diabetes and make life difficult, and to see what we can do. And much of that is not just being sensitive to patients' condition, but working in partnership, saying it's not what I, the frontline doctor, can do by myself, but what I can do in partnership with others.
Fantastic. Thank you so much to Sir Michael. And I'm sure that has touched a note with many of us listening to that there just now. So before we continue on, I will mention that we're recording this evening, and that's really so that we can make it freely available to everyone afterwards, which is always good to be able to go back and re-listen to things and to consolidate what we learn. And just briefly explain the format of this evening for the rest of the talk, we've got 3 speakers for you coming up, each presenting for around 15 minutes, with some panel comments and discussion at the end. And if you have questions for the speakers, which I would very much encourage, because we want to hear from you tonight, if you could put them in the Q&A box, and we will do our very best to keep a note of the questions that are coming through and pick out the main themes that are coming through from the audience. So without further ado, I'd like to introduce you to our first live speaker for this evening, Professor Simon de Lusignan. I knew I was going to get that wrong. I'm going to try that one again. Professor Simon de Lusignan. De Lusignan? De Lusignan. Simon is Professor of Primary Care and Clinical Informatics at the Nuffield Department of Primary Care Health Sciences, University of Oxford. And he's going to speak to us tonight about excess COVID mortality in the first wave. Thank you, Simon.
Good evening, Chair, and thank you to all of you who've given up your evening to come along and listen to this. There's a sense in my mind of how you follow what we've just heard, but I think I will be reporting that we still have disparities and that unfortunately we in the NHS haven't solved everything. So as we said, I'm Simon de Lusignan. I'm also a GP. I've been in my practice for over 34 years now, and although in a very posh town, look after the north of that posh town, which has the only failing schools in the county in which I work, etc. So I'm very, very much in awe and enamoured by our opening speaker. But I'm going to talk about excess mortality in the first peak of COVID. I'll probably just be around the 10-minute mark to allow plenty of opportunities for questions. So hopefully this will page down. I'm now just struggling to get my computer page down. Yes, so I've broken my talk up in the format of the paper. It was in the BJGP introduction, method results discussion. And if any of you are enthused to get involved with the college's Research and Surveillance Centre, from which the data practices shared data, which is used in this thing, then I will pop up a little advert slide at the end. So what we did is we set out to report the rates of mortality across the first wave of this pandemic. And this was a time there was very little community testing. And one thing we wanted to report was whether there was excess mortality, the extent to which age, gender, household size, ethnicity, and socioeconomic status were associated. We were also very interested at that time about any associated clinical diagnosis. The RSC has been a central network for years. And for example, GPs diagnosing acute bronchitis at the end of the year is the best clinical prediction of when RSV is circulating. And when we as GPs code influenza-like illness as a problem, that's the most sensitive marker of when influenza A. So we're interested in clinical diagnosis. And if a GP thought someone had COVID, was that associated with outcomes in a similar way to positive virology? And obviously we're interested in long term conditions. And we were also interested in people with learning disabilities, as this hadn't been looked at this stage in the pandemic. So I'll move on to our method. The data, as I've explained, has come from the RCGP Research and Surveillance Centre that's now very much integrated into work at Oxford. And what we've had for a while is a household key, which links people with identical address, so you can see how many people are in a single household. We capture where we record in the records ethnicity. We convert postcode to a measure of socioeconomic status. And we also, as I alluded to earlier, were interested in how COVID was recorded at a time when there were very few community tests. So a definite case was when we had a PCR virological confirmation. A probable case was when a GP had given a code when we recorded something which we could infer meant we thought this was a case of COVID. Possible case was implying a clinical suspicion. There's a word missing, I'm sorry. And not a case was a negative case of virology. If you don't know about the Research and Surveillance Centre, we're one of Europe's oldest sentinel system, and it's now in its 54th season of surveillance. And we're a network of practices willing to share data for surveillance, which is what I'm going to be talking about at the moment, quality improvement, research and education. So it was routine data that people have shared that I'm using this evening. So our analysis was to compare our mortality rates with those being published by the Office of National Statistics, to conduct a relative survival analysis comparing last year with the year before, and reporting the odds of the risk of mortality, comparing demographic and clinical risk factors. So what results did we get? The first thing is to show how fantastic now our records are with their electronic linkage. When you prescribe, you might see a little blue box sometimes that comes up if our patient's details don't match the national spine. But because of it, our details are very good. And this graph shows weeks across the bottom for 2019 and 2020. And then the ones with the hump in, which is unfortunately the first wave of mortality, have the RCGP data, which is in grey, and the ONS data in blue. And you might notice a small lag. And that lag is because we work off date of death, and ONS works off the certificated date of death. So that's why that small lag. We can see they're pretty good, and we have pretty good data on mortality. We put this data, in fact, into an interactive observatory, which people are welcome to look at and follow what's happening now. And I pinched this screenshot last night. And on the left, if I press page down, is the first wave of mortality, which we saw earlier in the year. And if I press down again, this is the wave of mortality that we've just been through. This last bit here, there's sometimes a little lag on the data. So it's possible we're now seeing a reduction in mortality, but we can't be certain yet. But you can see across both waves, and within this observatory, you can look at different age bands and sort of interact with it to see which groups are most affected. So we then looked at the relative risk of mortality, and particularly the things I wanted to focus on was male, and why males more than females. And it's, I think, largely a question that's remained unanswered. And also, interesting enough, what happened with household size. So compared with single occupancy, if you had households of 2 to 4 people, they had a lower risk of mortality than as houses got larger. And then when you got to addresses with more than 9 occupants, and we're starting to think about communal establishments, then in the first wave, the relative mortality was 5-fold. I've included in the presentation the adjusted mortality rates, and I'm not going to particularly talk through those now. and but they're there in the presentation, which I think is being distributed should people want to look at them. We also carried out an analysis looking across age, gender, size of households, population density, and found Black ethnicity. I've really listed the factors being severely obese and learning disabilities. And so many of the factors associated with disparities were associated with increased mortality. Interestingly enough, where a GP gave a quite definite code, they thought that someone was at risk of mortality, their risk was just as great as it was with a PCR diagnosis. Those GPs diagnosed with lower respiratory infections had a higher risk, and people at increased clinical risk because of comorbidities. This is unfortunately probably a bit detailed, but I've included this data again so that people can look. If I can just highlight within it that if you had a definite, virologically proven diagnosis of COVID, you had about a 9-fold risk. But if a GP gave you, or we gave people a diagnosis of COVID, again, the excess mortality was pretty high. Lower respiratory infections, again, a higher rate of male gender, which I've touched upon. Communal establishments, larger households, conurbations and high population density. We didn't see a particular signal related to deprivation, but Black ethnicity and being severely obese were also associated. So in discussion, we certainly saw that there were great disparities with mortality in the first wave. In addition to what was known about very quickly about age, gender, ethnicity, and chronic disease, we added quite early information about household size and people with learning disabilities. And we also found that some clinical diagnoses were also predictive of outcome. I've got to say, found across the piece, and I think for us as GPs, it's something we need to work with Deepend and others to try and do better at. But when we've looked just at people with known COVID status, we found a similar mortality. In diabetes, if we've looked at glycemic control, employers therapies, or who's referred and who's treated more positively in eczema, or access to electronic records, the pattern we've seen in COVID mortality, we've seen in other studies that we've done. And I think this is a massive agenda for us to address. So there were considerable disparities associated with mortality. We feel that there are lessons that we need to be learned from future clinical practice. And I'm a great fan of our first speaker and us aspiring in primary care to do better in this area. If anyone's interested in getting more involved with the RCGP RSC, if your practice become a member sharing data, please be in touch with us. This weekly report we produce has been produced every week for 54 years. And if you look at it today, we've seen in the last 2 reports that COVID in people under 15 is again starting to rise. And we've got a number of COVID resources, which if there's time at the end or whatever, I'm happy to show more of our interactive dashboards. But thank you much for listening and welcome any questions.
Thank you very much, Simon. That was incredibly interesting and useful. And I think we are very envious of the RSC in Scotland because we generally don't have practices linked in, and we need to. But the power of data and being able to detect things early and show trends and demonstrate workload as much as anything else has been quite difficult to establish in Scotland. So thank you so much for all those insights. It's 7:30, and just looking at the timetable for tonight, I'm going to try and stick to the times that we have for speaking, so we've got lots of time for panel at the end. But yes, please do put questions into the Q&A box for Simon, which we'll incorporate when we come to the panel discussion, if that's okay. So now I would like to introduce you to our next speaker, which is Dr. Sarah Hillman. And Sarah is a GP in South Warwickshire with a special interest in women's health. And she's also an NIHR clinical lecturer within the unit of academic primary care at Warwick Medical School. And she's going to speak to us tonight about socioeconomic status and HRT prescribing. Thanks, Sarah.
Thanks very much. My slides have decided to disappear, so I'm just bringing them up again. Hold on. Right, great. Hopefully you can all see those now. So thanks so much to the BJGP for asking me to speak this evening. I'm going to talk to you tonight about a paper that we published in October of last year. I think I'm the only speaker this evening not talking about COVID, but hopefully you will find what I have to say interesting. I'm going to talk to you about socioeconomic status and HRT prescribing, and a study that we did looking at practice level data in England. So I'm a GP in South Warwickshire. I'm also a clinical lecturer at the University of Warwick. But in my clinical work, I provide quite a lot of our women's health care, and I provide quite a lot of our menopause care as well. And it appeared to me that there was a difference in the women that were coming to speak to me and ask me about menopause care, and particularly request HRT. It became quite apparent that it was those women that I would have regarded as more affluent that were asking for help, and those that I would have regarded as more deprived weren't. And I wanted to know what the wider picture was. And of course, the question is, well, why does that matter? So just a little bit about HRT. So as I'm sure most of you know, that HRT, or hormone replacement therapy, is used to treat a plethora of symptoms during the perimenopause and menopause. And actually the vast majority of women, 80%, suffer with symptoms that can negatively affect their lives, not just their work life, but their home life as well. There's lots of different ways that HRT can be prescribed, but the most common are oral and transdermal preparations, and we'll come back to why that's important. So HRT is the most effective treatment that we have for menopause. In terms of social deprivation, I'm sure we're all aware that there's a higher rate of osteoporosis in areas of deprivation. Actually, women have a younger age going through the menopause in more deprived areas. And of course, cardiovascular disease and diabetes, there's a higher rate in more deprived areas. And then when we think about HRT, HRT is something that prevents postmenopausal bone loss. It's something that's recommended for women who have premature ovarian insufficiency, and is certainly recommended for women that undergo menopause early and to use up until the age of an average menopause at the age of 51. And HRT also can decrease cardiovascular disease in women under the age of 60 or within 10 years of going through the menopause. As far as HRT prescribing goes, there's been a large fluctuation in prescribing rates. Back in the 1990s, 30% of women aged 50 to 64 were current users, and 50% were ever users of HRT. And of course, everything changed with the premature closure of the Women's Health Initiative study back in 2002, which described an increased risk of breast cancer. This was put in the media quite a lot, and subsequently a lot of women requested to stop, and a lot of doctors were quite scared to prescribe, even though subsequent work looking at the WHI and also further studies have shown that actually breast cancer risk can change regarding the different types of HRT that we prescribe and the ways that we prescribe it. For instance, if it's prescribed on its own or if it's prescribed with progestogen, and what type of progestogen is used. There's a little bit of evidence that prescribing of HRT is slowly starting to increase again. So in terms of prescribing and deprivation, our group has shown that opioid, benzodiazepine and antibiotic prescribing is higher in rates in areas of deprivation. And the Women's Health Initiative did look a little bit at whether deprivation changed prescribing rates back in the 1990s. But the answer was it did change it, but not very much. It was far more influenced by a woman's medical or surgical background. And there's been no recent evidence regarding HRT prescribing and its link to socioeconomic deprivation, and hence the reason for our work. So we looked at cross-sectional monthly prescribing data in England over 2018 using NHS Digital. And we looked at the prescribing data at an individual practice level and a CCG level. We looked at socioeconomic status of a practice by looking at Public Health England's national general practice profiles. And the socioeconomic status was quantified using the Index of Multiple Deprivation Score. So that uses 7 domains, including income, employment, education, and they're all weighted. We then filtered the data for preparation type and aggregated it per practice. And we included oral, transdermal, intranasal and implant HRT, but we excluded progestogen only. And the reason for that was that we didn't want to double count HRT. And obviously prescribing a progestogen on its own is often something that we would prescribe for other things other than HRT. For instance, a Mirena coil being used for dysfunctional uterine bleeding. We then combined it with practice level IMD scores and the total number of women over the age of 40 in a practice list. And we also combined it with risk factors or clinical conditions that we felt might influence a clinician's prescribing. So they were things such as smoking, obesity, diabetes, hypertension, cardiovascular disease, and stroke and TIA. And then we looked at the HRT items per 1,000 female patients aged over 40, and we categorised it by IMD decile. So we performed the statistical analysis twice, looking at the association between practice level IMD and HRT prescribing rate. We did it unadjusted, and then we adjusted it, looking at those factors that we felt might influence prescribing and the practice female population. We then repeated it for oral and transdermal preparations alone. So we got data from almost 6,500 practices with over 14 million women over the age of 40 and over 2.5 million prescriptions at a collective cost of £38.5 million. Overall, there was 53% more oral HRT items prescribed than transdermal. So firstly, when we look at the unadjusted data, there was a stepwise decrease in prescribing rates from decile 1 to 9. So decile 1 is practices in most affluent areas, decile 10 is in the most deprived. So you can see that there's a significant association as the level of deprivation increases, then the rate of prescription goes down. And in fact, in the most deprived practices, you had a 29% reduced rate of prescribing of HRT compared with the most affluent. We then adjusted the data for those things such as smoking, obesity and diabetes. And even when we adjusted the data, the Index of Multiple Deprivation Score was still an independent predictor of HRT prescriptions. So in the most deprived areas, you're still 18% less likely to be prescribed HRT than the most affluent practices. We then looked at the data using splitting it up, so looking at oral and transdermal. And regardless of preparation, there's a clear reduction in prescribing. So in the more deprived practices, there's less prescribing of HRT. However, when we break it up, as far as transdermal preparations goes, there's a 45% difference in prescribing if we look at the most affluent compared with the most deprived areas. But with oral, there's a 15% difference between the most affluent and most deprived. Overall, there's more oral prescribing than transdermal in more deprived practices. So what does this all mean? Well, there's a stark association between prescribing HRT and socioeconomic status. And the big question is, does it reflect a wider unmet need for menopause care in more deprived areas? There's likely to be patient and clinician factors at play here, and we'll go on to talk a little bit more about what that might be. But there's proportionally more oral than transdermal HRTs prescribing in higher deprivation areas. And this is important because cardiovascular disease is associated with deprivation, but transdermal HRT preparations are safer preparations that have no increased risk of thromboembolism or stroke. So if anything, we should be seeing the opposite. So what could be influencing decision-making from the clinician side? Well, we know that in areas of deprivation, doctors are having complicated comorbid consultations. And I suppose the question is, does the menopause feature? There's the cost of HRT. And also in recent years, the ability to get hold of HRT. I think the risk of cancer still does play in clinicians' mind, and rightly so, but it should be proportional. And the risk of thromboembolism, but if prescribed transdermally, then that risk is negated. So how about from the patient side? Well, their thoughts about HRT will obviously play a role. They don't have access to private clinics or resources, and certainly in my practice, I see quite a lot of ladies that have accessed private clinics or resources and have come and asked me to continue their prescriptions. There's the cost, and many HRT preparations come with dual costs to the patient. There may be a lack of awareness of menopause symptoms and less discussion with family and friends about the menopause and HRT. If you don't know somebody who's using it, then you wouldn't know potentially to come and ask. There may be language and cultural barriers at play. And of course, a 10-minute consultation is not very long. And if this is something that's an extra part of a consultation, it's likely that the menopause isn't going to get discussed in a lot of detail. And of course, what we can't get away from is the effect of COVID and what that might be happening to our consultations around menopause care. So the next steps really are to explore the facilitators and barriers to HRT prescribing in areas of deprivation, and to look at individual patient data, because as I said, we've looked at a practice level. Also a further health economics analysis, looking at more than just what would be needed to make up the difference in deprived areas prescribing more HRT, but actually looking at those cost benefits for women that are then able to potentially work and resume caring responsibilities. Then there's the reason for prescribing oral versus transdermal and why clinicians are prescribing that way, and the effect of recent HRT shortages and COVID. So HRT is prescribed less as deprivation increases, and practices in deprived areas are more likely to prescribe oral rather than transdermal preparations. But the big question is, are the women who would benefit most receiving the least? And I think that they are. So I'd just like to thank Dr. Sharon Shantikumar and Professor Jeremy Dale at the Unit of Academic Primary Care that worked on this paper with me. I'm happy to take questions.
Thank you very much, Sarah. And again, if we could put questions in the Q&A bar, that would be fantastic. And we will bring them together at the end. I certainly learned a lot from reading your paper, Sarah, so thank you very much. And a lot of the clinician factors working in a deprived area really chimed with me. And I think it was a bit of a stark reminder as well that we forget how lucky we are in Scotland to have free prescriptions, because that's one factor we don't have to think about. So thank you very much for that, Sarah. And moving on now to our final speaker, I would like to introduce you to Dr. Paramjit Gill. And Paramjit is a GP in a diverse deprived practice in inner city Coventry and Professor of General Practice at Warwick Medical School. Paramjit will be speaking to us about the need to protect ethnic minority populations from COVID-19 post-lockdown. Thank you.
Thank you. Let's get my slides up. Brilliant. Well, thank you for inviting me. It's a great pleasure to be here virtually joining you all this evening. Our paper was really a discussion paper, healthcare analysis. There wasn't the scientific paper that Simon and Sarah highlighted with their own work. And it was done in, I have to own up as well, I'm a trustee of the South Asian Health Foundation, and we got involved with this, the emerging pandemic very early on last year. What I want to cover really is how some of the issues of, how minority populations have been affected, have been covered by Simon listed a few factors, but I just want to highlight some more as well. And I want to say something about health inequalities in general, and just to remind ourselves of some of the work that Michael Marmot and others have done, which has brought us to where we are, and something about ethnicity, because that really is a difficult concept to get a handle over, and it's it's a seminar workshop in itself, and the way we use it, it's very beneficial, but it has some problems as well, and a bit about migration and some suggestions for the way forward. So again, we've got to start with Julian Tudor-Hart in Inverse Care Law. It's seminal piece that he wrote in 1971, and it's up to all population groups, and particularly the minority ethnic groups, because the care does vary tremendously inversely to where they live. But just to remind that, Julian Tudor-Hart was also a clinical researcher. For us academics, he was our doyen, our forefather, who brought us, the disease registers, screening, surveillance, which, Simon's work and the Sentinel practices rely upon, and the chronic disease management, as well, the compassion of general practice of being a clinical researcher. So, difficult to follow in his footsteps. And a bit about ethnicity, and this is a definition that I used, given by Raj Bhopal, who's actually from Edinburgh. He's an emeritus professor there now of public health, and it was in 1994 when he defined ethnicity as shared origins or social backgrounds, shared culture and traditions that are distinctive, maintained between generations, and lead to a sense of identity and group, and a common language or religious tradition. So you can see how complex it is. But how do we measure ethnicity? Well, we all had a go at it on Sunday when we filled in the census form. And there was that questionnaire on ethnic group. Which one do you associate with? Now, myself, you may think it's simple. Which one do I opt for? Well, I went for the British Indian one, but I could have gone for a lot of others as well, because it's not so simple. Because where I was born was East Africa, where I partly grew up was India. I have parentage from there, but majority of my working life has been here in the UK. So where do I belong? Which group do I belong to? For the census, it was the British Indian, but at the moment, India and England are playing cricket. So I support India. But next year it'll be England in the World Cup. Hopefully going further than the quarterfinals. We'll support them to that. But usual thing is they'll come out of there and it'll be Nigeria or Cameroon or someone else. We'll start supporting them. You can see how fluid it is and how we change. So it's not a simple construct. It's complex. It's multidimensional. It's fluid. But we define it as self-determined. And the important thing is everyone has it. Everyone belongs to an ethnic group. It isn't them and us. We all have an ethnic group to define. So, we've got to see it from that point of view. And a bit about migration as well, because that really impacts on where we are, on terms of ethnicity. So this is, some going back to my O-level history, remnant days. Now, before 1066, England, Great Britain was invaded by the Normans, the Danes, the Romans. They all left their footprint here in terms of our language, and even, dare I say, the A1. The roads were there. They left their mark. Then we had going on, the migrations, particularly from the slave trade and the Irish migrants coming along. Then during the last century. It was the refugees and the Windrush generation who came to support the NHS, who were called to come and work for the NHS. So they took the call and came here. And again, it's the from the Indian subcontinent, particularly in the 60s and 70s, and particularly in 1971. Some of you may remember Idi Amin, basically told the South Asians to leave Uganda, and many of them arrived here and settled in places such as Leicester, where actually they came with nothing and have flourished and thrived and contributed substantially. And in fact, we heard a lot about Leicester during the last pandemic, just gone last year, where there were very high rates and lockdowns. This is taken from the last census, 2011, which shows you the local authority density of ethnic migrant populations where they live. You can see it's London and Greater London, the conurbations around the West Midlands, Birmingham, the Northwest, Manchester and Yorkshire, where we expect them, and that's where they are residing, and that's where we saw the mapping of the COVID pandemic being evolving. And sadly, last April, we saw these faces on our television screens of many of our colleagues appearing, as you can see, many of them from minority groups, who died of COVID. That was in April. That's when we first started seeing these. Well, why are there so many people in critical care who are minority background, a third of them, and why are they dying? And this picture started to evolve. We looked at some of the early data that was emerging, and yes, it was the Black population and the Asians who had a higher rate, and even adjusting for age, sex, and deprivation, and some of the morbidities such as diabetes. But it was still, the rates were much higher for hospital deaths. When we looked at the hospitalization by ethnic group, again, a similar picture, even by adjusting for these other confounding factors such as morbidity, lifestyle, and age. You can see the Black population and the Asians are still higher rates of being admitted compared to the white population, which was shown here. Then we looked at, well, where did we have the evidence for this? We had some good evidence, and this is shown by the green circles here, such as on, male, being male, you were higher rate of getting COVID. If you lived in a deprived area, if you were older, if you were overweight and obese, severely obese, particularly over the age of 40, where you had really double the risk of getting COVID. Ethnicity, that's been mentioned, and South Asians and the Black population. And even there, when we start to unpack the South Asian, because there's a heterogeneous group there, it's the Bangladeshis and the Pakistanis who have the highest rates compared to the Indians and the Chinese, then the whites. Why is that? What is going on there? And some of the morbidities have been mentioned, such as diabetes and hypertension. There was some evidence, indirect evidence of the wider determinants at that time and some of the behavioral factors. And there was no evidence for vitamin D, but that was really highlighted. That was going to be the panacea. Give everyone vitamin D and you solved it all. But like everything else, that didn't give us an answer at all. So it is the wider determinants which are playing a part here. And again, it's to highlight some of the landmark studies that have been going on. Now, the Black Report in 1980, which came out, was the first one, really showed that there were this social class difference in morbidity and mortality between the social groups. And then the Atchison Report in 1998 again showed these differences, and that these differences had increased. And in fact, they also looked at ethnic group as well and highlighted that. Then the Marmot Review 2020, again, that's been mentioned that also highlighted that fact. And again, February of last year, just before the pandemic, the Health Equity Marmot Review 10 years on, as Carey has said, again showed that there was this widening the differences, and that life expectancy had stalled. And during the previous the austerity years, that it had stalled during that time, and it had got worse for women. And actually, place matters, where you live matters. So being in a deprived area of the Northeast is worse than living in a similar deprived area in London. And why is that? That still remains elusive. Again, this slide shows that there's almost a 10-year gap between living in a life expectancy in men who live in the most deprived area compared to the wealthier area, and about 8-year gap in life expectancy for women. Well, why do minority groups have a higher risk of dying from COVID? It's not a simple answer. We haven't got it yet. People are looking at various factors, and these factors have been extensively documented for other conditions. When we looked at cardiovascular disease, diabetes, stroke, why do certain ethnic groups get them and not the others? That still needs unpacking. But we do know that there are a range of factors, from the upstream, the socioeconomic, the wider determinants, which Michael Marmot and others have highlighted, as well as the downstream biological factors. And it's this teasing out which needs to be done. But this is a complex thing, and we can't just rely on the statistician accounting for these confounding factors and saying it's this factor or something else, because they may be actually masking something else underlying that. And it comes down to this intersectionality aspect, where we have to look at the age, sex, ethnic group, social class, education, and dare I say, racism, which is at the moment difficult to measure and account for. What factor do these all have in putting people at higher risk? And the other thing that we have all noticed working in deprived practices, and multimorbidity, which occurs about 10 to 15 years earlier in our population compared to the not so deprived. It's complex, people's lives. We have to take account of their physical, psychological, social, and financial situation, which again, Julian Tudor-Hart, Michael Marmot have all, highlighted. And also in deprived areas, we have more consultations, yes, 20% more, but they usually tend to be shorter, and they're complex. The problems aren't just hypertension or diabetes, there's something else also going on, as many of you will have found out during the last year as well. So what can we do? Well, we must continue to communicate with our patients and the public, because there's still a lack of trust, especially amongst the minority groups, and particularly amongst the Black population. We need to have a consistent message, and this needs to be maintained on the hand washing, the social distancing, and wearing of masks. Those are so paramount, and we need to use different avenues of conveying this message. We can't just rely on the BBC or the Channel 4 News, which we may be used to, or the Radio 4s. Our populations don't listen to that or don't have access to that. We need to tap into the ethnic media that are out there, both the print and the social media there, and community champions and social prescribing. And we need to get our vaccination rates up amongst these groups, which are still not there. And again, monitoring and addressing health and social policies. We need to get the health impact assessments back on the agenda, because they've been lost during the last 10, 15 years. They were in many of the policies, but as we know, they've been sort of whittled out again. We need strong leadership within our communities, which reflect the population that's served. We need to collaborate with each other, the primary care networks. And again, we need to learn from lessons from, deep end practices, dare I say. who've done tremendous amounts of work. What can we learn from them and bring it to our locality? The training of staff, and we've got to look after our staff as we're coming out of the pandemic. Not only our patients, but our staff are very important because they are the key. They were the front line, and many of them worked, the patients as well, work in the gig economy, where they don't have sick pay, where they can't take time off, they have to go to work, and we have to take advantage of the new systems that are coming along from April. This integrated care systems and organisations, particularly in England here. And we have to, Carey mentioned the financial advisors as well in the deep end. It's a great example because we are seeing a lot of our patients coming up with these issues with the benefit system, which we don't understand how to, access that and how we can help. So we need experts to be able to do that and to have a honest national conversation about the wider determinants and what are we going to do about it. These wider determinants of health, such as housing and education and climate, and the atmospheric pollution, which all have an impact. And funding for primary care, that's again, it's as we know, it's a weighted capitation with so-called needs weighted, but that's really a proxy for activity, which doesn't account for the true need. And I'd end up that we need to ensure our data sets are complete and systematically recorded for planning, as well as for us academics for research, so we can monitor and surveillance, continue with that, and highlight with early warning signs what we need to do. And I'll leave you with a quote from Frederick Douglass, who was a slave and freed himself and went from Maryland to New York and became a great abolitionist and great orator. And he said, "Power concedes nothing without a demand. It never did and it never will. If there is no struggle, there is no progress." So I think that still remains, and Julian Tudor-Hart's message continues. Thank you.
Thank you very much, Paramjit, and a good quote to end on. So there's lots of questions coming in on the Q&A, and I wonder if it might be worth the speakers all just opening that up on their screens as well, so that they can see some of the questions that are coming in, and feel free just to push out ones that you feel you particularly want to jump in and answer. But I guess sometimes it's easier just to kick off with one, if that's okay. And I was going to start with Paramjit and go back in reverse order, just because you're freshest in people's minds because you've just finished speaking. And it's, what can we do as GPs to address these ethnic inequalities? There's a lot of discussion in the Q&A boxes around, do we record it well? Is there anything else we can do? What is the role of GPs? And so it would be good to hear some thoughts from the audience as well about what do you think, what do we think we can do as GPs to address this?
I think the fundamental thing is good data, and we are lucky in having a very good primary care data set, well renowned around the world, but we could still improve upon it, and we need to get that systematic recording of it and monitoring, which then our colleagues like Simon can look at it and keep an eye on it for monitoring and planning. It's very important to look at the trends. And we need to work with our colleagues within now the primary care networks, whatever we may think about, this is the system we've got now. And actually there are many benefits to learn from what is the practice down the road doing, how they're managing to get their flu vaccinations rate up. And I'm struggling here with my South Asian population. What are they doing which we could learn from? We've got to champion the uptake of because the unintended consequences is that the chronic disease management, cancer referrals, and cancer detection have all gone to the wayside. We need to look at that and how we're going to improve the preventative services such as screening, breast and bowel, and which are very difficult again amongst the minority population. They are suffering more with breast cancer. That is becoming an issue, and bowel cancer as well. 20, 30 years ago, it was unusual to get South Asian and Black populations coming in with symptoms of bowel cancer, but now we see it commonly. So again, it's due to the environmental factors, I'm sure, but we need to look into that. So I'm sure we can look at our colleagues in the virtual chat to give us some more.
Absolutely. No, that's a good list to start off with. So I've written down: collect good data, work with colleagues, share learning, prioritise prevention. Then we've got some really interesting things coming in on the chat bar as well. Our GPs encouraging their patients to complete the census so that we know who lives in the country and we can design services around them. How do we know what evidence is missing? If you don't know, you don't know. Do we need to be more honest about explicitly naming racism as a fundamental barrier, addressing its adverse impact on the healthcare industry? So lots of really good stuff coming in here. Please keep putting it on the chat bar. Simon, you wanted to come in about data quality, which of course is really important. There's no point in collecting bad data.
Yeah, I try and avoid the data quality phrase as I watch people nod off to sleep as I use it. But I tend to be more provocative and try and give two messages. One, coding is caring. So where we're trying to sort out these ethnic differences, we're looking at, notwithstanding all Paramjit's, which label do you use, but leaving aside that, we have to take a patch of the country like a local area and then guess from the what the census data says about ethnic distribution to make up for missing data. So my big adage is coding is caring. If you really care about getting to the bottom of these issues, code or use your clinical terms and code data, because then in terms of ourselves knowing how we're doing in terms of quality of care, but also doing this analysis is it's so important. And if coding is caring doesn't motivate you, my other phrase is bad informatics kills. And we've all sat there going through results and you can't tell whether someone's on their methotrexate for psoriasis with a different cutoff for stopping it or because of their arthritis. And we have practices we take into the network, about a third we can't use for our weekly report. We do use for other things because the data quality is below the recorded threshold. So please really go for it, because it will make it easier to address these issues.
Thank you, Simon. And again, some really interesting points being made here about, what is it that we need? Time has come through, time to listen, to build trust, to work with communities. You mentioned, Paramjit, that in more deprived areas, we do 20% more consultations and they tend to be shorter because something has to give, and they're more complex often with a higher number of problems and more comorbidities. And I wanted to come on to Sarah with that point, because when we're thinking about, I guess, clinician and patient factors and discussing what could be quite complex things like HRT, I wondered what your thoughts were on how we better understand what some of those barriers might be, both from a clinician perspective and also from a patient perspective. And there's also quite a few questions coming through about the impact of ethnicity on patients coming forward around HRT.
Yeah, so I think that there's, as we've said, there's big patient and clinician factors at play here. And I suppose the question is, you can't tackle one without the other. So I saw in the chat somebody saying, it's really interesting that you say, but I work in a very deprived place, and actually patients that ask for HRT always ask for tablets. They don't want patches, which is really interesting, isn't it? Whereas if you work in a more affluent practice, I suspect that quite a lot of women are coming asking for HRT that they've been possibly prescribed or seen their friends or family members having, and they're having transdermal. So you ask for what you know, don't you? And you feel safer with having something that you know your friends having as well. So I think some of it is going to have to come through enabling patients to be able to talk about things such as the menopause, and in some areas, and particularly in some ethnicities and cultures, that's probably something that's not discussed very much. So some of it's got to happen even before the patient gets to in front of the GP. But then when they're sat down there with the GP needs the time and they need the resources to be able to have a one-to-one discussion around menopause and prescribing. And I think somebody said, 10 minutes isn't long enough. And actually, a full consultation about symptoms that you've worked out as a clinician is the menopause, and the patient doesn't even know that they're the menopause yet, is going to take longer than 10 minutes to even get to the end, let alone when you start describing actually what's quite complicated prescribing and needs to be tailored to the patient. I see a lot of people asking about ethnicity. We couldn't look at ethnicity because we were looking at sort of practice level data and we didn't have that data. The only way we can get ethnicity is to look at individual patient data, which we hope to go on and do. But just to say that there has been big studies done in America, such as the SWAN study, looking at ethnicity and symptoms of the menopause. And they found that actually African American women and Hispanic women actually suffered with far more vasomotor symptoms than Caucasian women. So it's not that women from other ethnicities don't suffer with symptoms of the menopause, they do, but they're not accessing and getting the care. And I think that's the important thing that we need to address.
Thank you, Sarah. Lots there. And so much of it often does come down to just having more time to have the conversations about what matters to people and understanding what their choices are. An interesting question, this is on the chat rather than on the Q&A. I don't know if everyone can see it, but it's going back to Sir Marmot's reflections on the tension and scepticism about public health being viewed as something that we do in general practice or in primary care. And I've certainly noticed over the last year there's a growing interest in how can we collaborate more with colleagues in public health, because we both have really crucial roles to play in population medicine. Almost public health at a macro level, general practice at a micro level, feeding into each other with different training, different expertise, different things to bring to the table. How do we achieve better collaboration and tackle some of that scepticism? I'm not sure who would like to tackle that question first. It's a kind of general one.
Well, shall I start off then?
Please, yeah.
It's just sort of a thought. It's sort of, how can we make our systems resilient? And we can't do it on our own. So we have to look around and what's around, where our practice is. We think about our practice, where is this sited? It's not only the area around, the housing. Who else is there? What other services around that we can tap into? We've got to think about, because again, Simon highlighted the disease surveillance. That's really is public health. Broadly, maybe one practice, but when you talk about a locality, that's the public health approach. So we can buy into that. But if we look into, for example, the number of people who need housing, because I'm sure that's another issue that many of us who work in these practices face. My house is not fit for purpose. What can you do about it? Now, it's a great struggle. I know some of you in certain parts where a few years back, the local authority said, don't bother writing housing letters. They don't do anything. Don't bother. This is the message they sent out to us. But how can you not bother? You're the patient's advocate. You've got to make a case for it. In a way, when someone says not to do it, then you have to keep on at it, because otherwise they've got no one to fight for them. So I think we've got to this patient advocacy. That's the public health role we've got to take on.
Thank you, Paramjit. I know that, Simon, you're interested as well in what's the role of general practice been during the pandemic and surveillance, which I guess is a public health, maybe traditionally a public health role, I don't know, or maybe it is traditionally a general practice role, or maybe these functions are becoming greyer and merging. What are your thoughts?
Well, I've got to say I've been overwhelmed with the interest we've had from colleagues, and we started off taking samples at the start of the first wave in surgeries, had to move to sending a postal remote service, tremendous adaptability, but there's just been a phenomenal wave of interest. We went into the pandemic with a network of 500 something practices. We've left it with just under 2,000. We've just had phenomenal interest of colleagues being willing to help. And through the network, for the first time, we've been recruiting to trials, and we've been most proud of our contribution to the principal trial, led by my colleague Chris Butler, that's really shown that antibiotic use isn't of use, and not only, if you like, involved in the cutting edge of surveillance, but actually trying to do in pandemic trials, so we don't end up with the mess perhaps we're in with antivirals for influenza, where there were never trials, so we never really knew whether they worked or not. So it has been I've been touched by just the enthusiasm and willingness of people to help across throughout 2020.
Thanks, Simon. There were some discussions posted at the beginning of the Q&A actually about, and there's been quite a lot of themes coming through, I think, tonight around the need for collaboration to meaningfully tackle health inequalities. It's not something that GPs can do on their own. It's not even something that general practice teams can do on their own. We need to be reaching out to colleagues in the third sector, voluntary sector, and wider primary care teams, and also colleagues in non-health. But there was some interest at the beginning around what's the role of social prescribing and getting involved in community projects, and some mention of link worker schemes as well, which some of you may have thoughts on or be familiar with. And I just wondered what your thoughts were on that role of general practice.
Well, again, if I kick off, it's we actually use some of these social prescribing within the practice. I know people looking at the evidence and its gathering, and people will do the equivalent of trials or observational studies, but they are of benefit. We need people to signpost, because we don't know what's out there. It really is a complex world. Once you get out of your surgery doors, where do the people go? But people know, who live there, what's down the road, what community group is, who can help me, and there's some gardening initiatives starting where people can go into a allotment and help out. So those kind of initiatives which brings people together. And it's of benefit of not only on their physical but also their mental health as well. But it's creating a cohesive local community. Now that's easier said than done, but it takes these little steps to bring that together. There's that cohesion to work together. But yes, social prescribing is going on, and it's in many forms. Some practices where I am, they even have patient walks as well. Led by patients who go, around the park at lunchtime. About 6 or 8 of them are usually walking around. Well, great for them. It's bringing that together, that cohesion. Thank you,
Paramjit. And certainly in practices in Scotland, where we've got a reasonable number of link workers and a new amount coming out into the system, which is fantastic. They're a hugely valuable part of the team, because so many of our patients, as we know, struggle to navigate the complex systems like the NHS. It's not a simple case often of just saying, we suggest you do this. It needs more than that. It needs a relationship to be built. It needs trust to be built, and often it needs someone to journey with them to that new experience. And I think it also highlights the need for a sustainable and well-resourced third sector, because you can only signpost to things if they're still there. And of course, that is going to be problematic, I think, as we come out of COVID. There were some questions, Sarah, in here as well around cultural barriers to HRT. and just asking for some examples of that. So I wondered if you would like to pick up on that one.
Yeah, so there wasn't a qualitative side to this study, but again, that's something that really needs to be done. But sort of anecdotally, I think that there are sort of some cultural barriers to HRT. I think there's some cultural differences between taking prescribed medicines anyway, and whether you want to take medicines or not. And then when you start looking at different ways of taking medicines, then people have different ideas about, you know, whether they're as effective if they're going through your skin, for example. But again, that's another piece of work that desperately needs to be done, because we need to know what these women know about menopause and menopause treatment, and what they want as well, so that we can align their thought process with the doctor's thought processes, so that you know, everybody's getting the right level of care. But yeah, the qualitative side of the work certainly needs to be done.
Thank you. That's great, Sarah. A couple of questions, and then I think we're probably going to have to wrap up, but there are loads more in here that it would be really good to tackle. So I'm hoping that you've had a chance to read some of the stuff that's coming in as well. There's a few questions coming through about the move to more remote consulting and digital healthcare, which of course has both benefits and risks associated with it, particularly when we're caring for people in more deprived communities where digital poverty and digital exclusion can be a huge problem, particularly when English is not a first language. So I would be keen to hear what your thoughts are on how we mitigate the risk of digital healthcare. Sorry, I know it's not completely on the topic theme, but it's something that's coming through quite a lot, and I guess we're all doing it as GPs in our consulting. But so some reflections on how we keep it safe and keep it fair for people as we're working in a different way.
Yeah, I've got a bit of a reflection on that, Carey, in that we've just done some recent work looking at contraception prescribing and contraception during pandemics and times of disasters. And what we're finding is that although working remotely, we can still do prescriptions, it certainly prevents certain types of contraception, and there's the big safeguarding element as well. So we don't quite know if anybody else is listening in at the other end of the phone. We don't quite know if there's any coercion going on. So it's a case of remote consulting has got lots of benefits, and actually I think there's plenty of things that we're not going to go back to, but we just need to be aware of the limitations of it, and certainly the safeguarding side of things, particularly for people in more in more deprived areas, and particularly thinking about things like women and domestic violence rates and those sorts of things, I think.
Absolutely. So where privacy and safety are issues as well as the other things that we've mentioned. There's a really good question here, and I'd love to know the answer. So I'm going to put it to the panel. And even if we mull over it for the next couple of minutes, somebody's asking if they were to take 3 quick wins back into their practice to address some of the health inequalities that we've talked about tonight. Can the panel suggest any things that could be kind of meaningfully translated in what we do day to day as GPs? And anyone else, of course, in the audience who has 3 quick wins to put in the chat bar or the Q&A would be most welcome, because it's not an easy thing to address or fix, and sometimes it can feel like a very big, overwhelming topic that is too difficult to address. But I think we've talked about some of the specific things that we can do. So maybe just if we had 3 things that we could choose, what would the panel go for?
I'm happy to have a risk. My risk would be you've got to go for longer consultations, because so that you can take a more holistic agenda with individuals. I think some sort of engagement with the community, which again, I'm just one of the positive things out of the things being touched on happening with PCNs is we are having more regular discussions with borough and council in terms of services. So I think that is something that is important. And I may have to stop to let's come up with some others. Probably my high quality records, it's got to be number 3, because if you're not really recording things well, and I think also as it skimmed through in the questions, there was a thing about homelessness, which isn't just being houseless, but those who are in the sort of sofa surfing, and all the grades of homelessness can be coded and recorded in records. And that's again so important for health outcomes. And when you see it in a record, it again pings as someone who needs some extra attention. So relevant record quality would be my 3rd thing.
Absolutely. Sarah, any thoughts from you?
Yeah, I was going to say very similar lines. My 3 things would be code, ask, and time. So without coding, we don't really know what's going on. Without asking, you don't know what's going on with the patient, and without enough time to have those consultations, we're never going to finish those consultations, and actually both sides aren't going to be aligned.
Thank you, Sarah. And Paramjit?
Well, just to add to those very good suggestions is to get your practice, talk to them, get them on board, because it's a team. You need to start with that. And the other one is who's your local MP? They're the powerful people. You know, they will open the doors for you if you badger them and hassle them, and get them onto your side and bring them to your practice and show them what it's like. And dare I say, even take them to someone's home when you do a home visit. Open their eyes.
Brilliant. Some really good suggestions. I'm writing them all down here. So community engagement, get to know your community. What do they want to know? In an ideal world, longer appointments, particularly for people who need them. And there's a good evidence base around that with studies like the Care Plus study. Accurate coding and relevant records. Somebody's also mentioned continuity of care in the chat, where you can do that and minimize handovers. It builds trust and it reduces unnecessary investigation and referral, and I guess offers more realistic medicine. Ask the patient what's wrong and what matters to them. Ask your team how you can do things better. Make it easier for, this is one I was going to add in, make it easier for people to register with a GP. And don't insist on photographic ID, proof of address and proof of asylum status. People have a right to primary care in this country, and it would be great to see more people registered with GPs. Get political, invite politicians in, let them see what we do, let them understand the work of general practice, let them get to know the constituents that they are looking after, and act as an advocate, which is going back to what Paramjit was saying earlier on. So I think that pretty much takes us to 8:30. We've got more than 3 things to take back to our practice. I hope that's okay. We've got to be aspirational about these things, but it's been a fantastic evening, and thank you so much to our panel. Thank you to Simon, thank you to Sarah, thank you to Paramjit, thank you to Michael for his virtual appearance as well and setting the tone for the rest of the evening. And of course, thank you to Euan and the BJGP team for pulling all this together. And of course, thank you to everyone who's dialed in tonight and made such amazing contributions and really stimulated some interesting and inspiring debate. So I hope you all have a good rest of evening. Keep going with the amazing work that you do, and it was lovely to meet you all. Thank you very much.